All right, let's dive into one of the most complex areas in clinical psychology, the schizophrenia spectrum. What we're going to do here is build a systematic framework, a kind of mental map, so you can navigate these diagnoses with real precision. Let's get started.
So, first things first, we have to get on the same page about what psychosis actually means. At its core, it's a state where someone loses contact with reality. And this shows up in two main ways. You've got delusions, which are these fixed, false beliefs that just don't budge, no matter the evidence. And then you have hallucinations, sensory experiences like hearing voices when there's nothing actually there. This idea of psychosis, it's the common thread that runs through everything we're about to talk about.
Okay, so those experiences get broken down into 5 core symptom types. We've got the delusions and hallucinations we just mentioned. Then there's disorganized speech, which is really a reflection of disorganized thinking. Number 4 is grossly disorganized or even catatonic behavior. And finally, we have negative symptoms, which are all about an absence of normal functioning. Keep these 5 in your head. They are the absolute building blocks for every single diagnosis we're going to put together.
So, with these building blocks in mind, how does a clinician possibly bring order to all this complexity? Well, the answer isn't guesswork. It's using a systematic approach, what you can think of as a diagnostic decision tree.
And that really is the central question, isn't it? When you're faced with these profound, often confusing symptoms, your starting point has to be a rigorous, logical pathway.
In this slide, this lays out that exact pathway. This is probably the single most important rule in the differential diagnosis of psychosis. First, you always have to rule out substances, medications, or another medical condition, always. After that, duration becomes your number 1 sorting tool. Then you look at mood, and finally the specific nature of the delusions. This hierarchy is the roadmap we're going to follow for the rest of this explainer.
So let's start with our anchor, our central reference point for the whole spectrum. Pretty much all the other psychotic disorders are defined in relation to this one. If you can really understand schizophrenia, you can understand the entire spectrum.
Okay, so the diagnostic criteria for schizophrenia are really specific. You need at least 2 of those 5 core symptoms present for at least a month. And this is key. One of them has to be delusions, hallucinations, or disorganized speech. But the total period of disturbance, including the lead-up and lingering phases, needs to last for at least 6 months. That 6-month line in the sand is what separates a time-limited issue from a chronic illness. And critically, it has to cause a real, noticeable decline in the person's ability to function.
Now, let's talk a bit more about those negative symptoms because they're often misunderstood. When we say negative, we don't mean bad behavior. We mean the loss of a normal function. So you get flat affect, a diminished emotional expression. Alogia, which is a poverty of speech. Avolition, a serious lack of motivation. And hedonia, the inability to feel pleasure from things. And asociality, a total withdrawal from social life. These are just as fundamental to the diagnosis as something like hallucinations.
Let's just hammer this point home one more time because it is an absolutely critical differentiator. A decline in functioning isn't just a possible side effect of schizophrenia, it is a mandatory criterion for the diagnoses. If you don't see that decline, you have to start thinking about other diagnoses. Okay, so we've got schizophrenia locked in as our anchor. Now let's go back to our decision tree and grab that first sorting tool, time. When it comes to the core psychotic disorders, duration is truly the key. And this timeline just makes it crystal clear. If the psychotic symptoms last for less than a month, and the person returns completely to their previous level of functioning, you're looking at brief psychotic disorder. If it's between 1 and 6 months, it's schizophreniform disorder. And as soon as you cross that 6-month mark, the diagnosis becomes schizophrenia. It's a clean, clear progression based purely on time. Next up, after we've sorted by duration, we start to analyze the symptom profile itself. And specifically, we're looking at 2 things, the role of mood and the nature of the delusions. Now, this comparison is absolutely essential. In schizophrenia, any mood episodes are pretty brief or just not there at all compared to how long the illness has been going on. But in schizoaffective disorder, a major mood episode, we're talking major depression or mania, is present for the majority of the total duration of the illness. The psychosis and the mood problem are basically co-pilots. They're co-primary disturbances.
So you might be wondering, well, how do we know the psychosis isn't just a symptom of a really severe mood disorder? That's a great question, and that's exactly what the 2-week rule is for. To make a diagnosis of schizoaffective disorder, there must be a period of at least 2 weeks where the person had delusions or hallucinations all on their own, without a major mood episode happening at the same time. This is what proves the psychoses is an independent issue.
Okay, now listen to this statement. My neighbor is poisoning my water. It's clearly a delusion, but it's plausible, right? It's not totally bizarre like believing aliens are controlling your thoughts. This kind of non-bizarre, often paranoid delusion is the hallmark of another disorder on the spectrum.
And that would be delusional disorder. This is defined by having one or more delusions that last for at least 1 month. But here's the key. The full package for schizophrenia has never been met. You don't see significant hallucinations, disorganized speech, or negative symptoms. And, this is huge, apart from the direct effects of the delusion, the person's overall functioning is pretty much intact.
And that brings us right back to the top of our decision tree. Remember rule number 1, substance or medication-induced psychotic disorder. This is the diagnosis when the psychosis is a direct result of, say, a drug or a prescribed medication. This is never an afterthought. Ruling this out has to be the very first step you take.
Okay, so we've laid out all the individual pieces of the puzzle. Now let's put them all together in one clear, concise view.
This master table basically synthesizes everything we've just talked about. Let's just walk through it real quick. You see the columns. First up, duration. That's our primary sorter, right? Less than a month, 1 to 6, or more. Then look at functional decline. See how it's not required for brief psychotic or schizoformiform, but it is absolutely mandatory for schizophrenia? Then you have the presence of a mood episode, which is what separates out schizoaffective disorder. And that last column, key distinguisher, gives you the single unique feature of each one. This table is the entire decision tree in a single glance.
So after all that, after drawing all of these neat lines and putting things in boxes, we're left with a really big, important question. Are these truly separate, distinct disorders? Or, in reality, are they just different points along a single, continuous spectrum of psychosis? That's the question that's still shaping so much of the research and clinical thinking in this field today.